Good afternoon again. So my topic is new perspective on therapeutics. Here are all my conflicts. So a good place to start this discussion is by stating something that we can all agree upon, and that is that there is an unmet need to improve clinical outcomes, quality of life, and ultimately premature mortality in patients with NASH. So that's really the question, that's the holy grail, that's what we're trying to go after. Because if we fail, the consequences will be quite serious. So these are based on model data that we published earlier this year, that as the current cohort of people with fatty liver disease age, many of them will progress to cirrhosis. And over the course of the next 15 years, the number of people with cirrhosis will triple. The people with decompensated end-stage liver disease will rise in the US to about 300,000 from the current numbers of about 100,000. And what is particularly frightening is that most of these will be today's children. So we need to attack this problem. And so if you're going to attack this problem, you need to understand what the problem is first. So in the course of fatty liver disease, as NASH progresses, it's useful to think about it like a metro station, where a major stop is cirrhosis before you get to the final stop, which is the mortuary. But the causes of death change as we progress. In this earlier phase, the primary causes of death are cardiovascular, cancer, and occasionally hepatocellular carcinoma. But once cirrhosis develops, cardiovascular mortality is still number one, but liver-related mortality and cirrhosis-related mortality and HCC start becoming more and more important. So with that background, we need to ask ourselves, what do we hope to expect from treatment? Before we rush into all these clinical trials and start showing data about this trial versus that trial, we need to be very clear what it is that we are trying to accomplish. So in order to understand that, it is important to understand two concepts. First is the concept of disease activity, and the next is the concept of disease stage. Imagine, if you will, a normal liver that gets affected by this disease and over time progresses to cirrhosis. Disease activity refers to all of the biological processes that are driving the disease toward cirrhosis. Very similar to if you're driving a car, it is the number of RPMs on your dashboard. It shows how hard the engine is working. The disease stage tells you how far you've progressed on this journey towards cirrhosis. So the disease stage is the odometer on your dashboard, which tells you how many miles you have traveled. The disease activity is the number of RPMs on the machine. So we traditionally assess activity histologically by the presence of steatohepatitis as opposed to fatty liver and various activity scores, whereas fibrosis is the principal readout of disease stage. So very important to understand that disease activity drives the disease stage, and disease stage is a marker of disease progression. And because it is a marker of disease progression, disease stage is more closely linked to clinical outcomes. So when you go to the AASLD and EASL, you hear people jumping up and down saying fibrosis is important, no activity is important, this and that. It reflects a little bit of lack of understanding of the disease. The two are very closely interlinked. One relates to the other. And since disease stage tells us how close we are to cirrhosis, and cirrhosis is what relates to liver-related outcomes and mortality, it is no surprise, it is the closest thing to cirrhosis and so most closely linked to clinical outcomes. So if you're going to benefit patients, you have to improve ultimately clinical outcomes. Everything else is a surrogate. So even the development of cirrhosis, you don't die because you have cirrhosis. You die because you get complications of cirrhosis, you get ascites, hepatorenal syndrome, go into a coma, variceal bleed, sepsis, multi-organ failure. That's what kills you. So cirrhosis is what is considered a generally accepted surrogate. And there are two types of surrogate endpoints. One is what's called a generally accepted surrogate, where clearly there's a huge amount of data that tells us that a change in health status has occurred. Very similar to hemoglobin A1C for diabetes. Whereas a reasonably accepted surrogate is something that makes a good story, but we do not have the data yet to say, like a generally accepted surrogate, to clearly link that surrogate to a clinical outcome. So changes in histology in the short term are what we call reasonably accepted surrogates. Progression to cirrhosis is a generally accepted surrogate, and ultimately changes in liver outcomes and death are what we call clinically meaningful outcomes. So what has emerged over the last 10 years is this understanding of the biology of the disease, which starts with a metabolic disturbance, where you are pouring in fatty acids, cytokines, glucose into the liver, and so it's a nutrient overload of the liver, which induces cell stress. If the cells cannot adapt, they will undergo death, cell death. This process of adaptation, cell stress, cell death, triggers inflammation. Inflammation begets more inflammation and eventually triggers fibrogenic signaling. And as Dr. Mara showed this morning, there are also extrahepatic factors that contribute to each of these steps. So if you think about this, you can think about drugs that can work on the first few steps, and these are the activity modifiers, because these are the biological processes that drive the disease activity, and fibrosis is, of course, disease stage. So you can have fibrosis modifier or a stage modifier, and this gives us our current sort of basis for pharmacological therapy of NASH, where you can start with drugs that affect the metabolic disturbance upstream, so you shut this gear off, everything else will stop, and the further lower down you go, you can put a brake in the place, but if these gears are still turning, you still have a problem. So that's a very fundamental concept in terms of therapeutics, that you have to treat the root cause. If you don't treat the root cause, you still have a problem. You have not fixed the problem. So in terms of understanding this, there is tremendous debate about the relevance of fibrosis and demonstrating that fibrosis actually improves in the context of treatment. So let's critically review what this fibrosis really means. So again, going back to our metro station paradigm, as you go from NASH to cirrhosis, the hallmark of this progression is increasing fibrosis. Similarly, we know that from cirrhosis to mortality, based on our Gilead studies, we show that more fibrosis you have, the more likely you are to die. So let's review these. In the pre-cirrhotic stage, let's think about what is clinically meaningful. Clinically meaningful endpoints relate to how a patient feels, how a patient functions, and how a patient survives. So worsening fibrosis from stage 0 to 3, does it affect how a patient feels? We just don't have any data to really say that. Does it affect how a patient functions? Really no data to suggest that someone with stage 2 functions worse than stage 1 or stage 0. Or how does a patient survive? Well, the main outcome at this point is cardiovascular and cancer, non-hepatic cancer. So if you are really critical, you could argue, who cares? So fibrosis, I have not been able to connect the dots between fibrosis and anything that is meaningful to the patient. It doesn't matter if it's meaningful to you, because you have your own biases. You're not really the patient. Nobody cares about what you think. What matters is what the patient thinks and what's important for the patient. So if the patient doesn't improve in terms of feel, function, and survive, you have not met your goal. So what is the relevance of fibrosis? So the fibrosis relevance is because it's a marker of disease progression towards cirrhosis. That's what it is telling us. Are you moving in the right direction or are you moving in the wrong direction? But fibrosis is important because when you look at the liver under the microscope, that's the most important thing. It jumps out at you as soon as you look at the liver under the microscope. But disease progression is not just fibrosis. Disease progression includes metabolic reprogramming, cell death, stem cell recruitment, regeneration, cell differentiation, changes in microcirculation, changes in the matrix, changes in bile flow, so much biology going on. We just see the fibrosis under the microscope and we focus on that. And just like in endoscopy, we always tell our fellows not to focus on the first abnormal thing you see. You got to go all the way to the end and work your way backwards and systematically evaluate the entire GI tract. Same thing over here. We need to really think about the entire biology of the process. So the implications then, this morning I was talking to the young investigators, even when something is significant, you got to address the issue, is there cause and effect relationship? So what is if you show a change in fibrosis, what is the causality that you are actually improving the disease state? And that depends on biological plausibility. And there are three basic mechanisms by which you can improve this fibrosis under the microscope. First, by reducing activity, because activity, as we established by definition, drives fibrosis. And so there is high biological plausibility. So drugs in the pre-cirrhotic stage that act on disease activity and then also improve fibrosis are likely in the long term to reduce progression to cirrhosis, because that fibrosis is a marker of progression to cirrhosis. On the other hand, if you have a primary antifibrotic drug in this population, it's uncertain what will happen because there's so many fibrogenic pathways. Fabio beautifully showed this morning, multitude of fibrogenic pathways. You block one, there are others still cascading around it. And so you really have to think about this type of approach. And if you're going to use this type of approach in the pre-cirrhotic state, you may have to combine it with some other therapeutics for combinations. But it may position the drug for combination therapy. And of course, there are individual cases where you will have both types of effects in place. The next issue is, once you develop cirrhosis, how important is fibrosis then? So if you think about, again, putting the patient in the middle and starting with the patient, clinically meaningful outcomes comes from clinically significant portal hypertension and a decline in liver function. So that leads to variceal bleed, ascites, SPP, HRS, sepsis, encephalopathy. And so what we need to show is if the HVPG improves, that for a given specific mechanism of action, the HVPG improvement actually translates into improved clinical outcomes. Once you show it for one or two agents, then every other agent using the same mechanism of action, you can just show a decrease in HVPG. It becomes a generally accepted surrogate at that point, but we're not quite there yet. And the reason being, you can put a TIPS in, very effectively reduce HVPG in many severe advanced cirrhotics, but survival outcomes are hard to show in randomized controlled trials. So it has to be mechanism of action specific. And then decline in liver function, something we have now got agreement with both the FDA and the European agency, is that if your MELT progresses to 15 or higher, we know your transplant outcomes then are better than medical outcomes. And usually that's sort of a minimal criteria for evaluation for transplant. So, but for people to go to transplant list, many things have to come together. So we understand that. But all other things being equal, if your MELT gets to 15 from less than 12, because there's lab variability, then that is also considered a generally accepted surrogate. The next thing to think about in terms of therapeutics is that unlike hepatitis C, which is a primary liver disease, NASH occurs in the context of diabetes and cardiovascular disease. And there is a tremendous amount of shared biology between these conditions. So if you think about as the liver disease progresses from fatty liver to NASH to cirrhosis, we have increased atherogenic risk factors, you have subclinical disease and heart failure. But underlying all of this, there is ectopic fat deposition in your end organs, followed by inflammation and injury, and then fibrosis. Let me explain. So in NASH, we know you have fat, you have cell injury, you have inflammation and fibrosis. We all know this. In atherosclerosis, guess what? You have fat, you have inflammation, and you have fibrosis, accumulation of macrophages. The biology at a molecular and cellular level is virtually identical to NASH, except it is happening in artery. Similarly, if you take patients with NASH and you exercise them, even in the absence of cirrhosis, you find that their exercise time is decreased, their VO2 is decreased, and their filling pressures increase. So the ventricles become stiff. The more you scar up your liver, and this is based on fibrosis stage 1, 2, 3 over here. We excluded cirrhotics in this study. This will hopefully come out in hepatology soon. But what we see over here is that as your liver becomes more stiff, your ventricle becomes more stiff. And so it can pump fine, but it does not fill fine. So the more scarred up one organ is, the more scarred up the other organ is. And in animal models, we have now demonstrated that indeed the heart develops this fibrosis, and the same molecular signals that you see in the liver are recapitulated in the heart. So heart failure with preserved ejection fraction is sort of like cirrhosis of the heart. You get progressive fibrosis in the heart, and very similar lipotoxic stress that drives inflammation, that drives fibrosis. If you look at this pathway, fatty acid lipotoxicity, ceramides, mitochondrial dysfunction, ER stress leads to beta cell dysfunction, apoptosis, and beta cell loss and type 2 diabetes. This is exactly what Dr. Mara showed this morning for NASH. So if you replace the beta cell with hepatocyte, then you have NASH. So essentially you're talking about the same disease. So coming back to our basic paradigm of metabolic distress causing apoptosis, inflammation, fibrosis, if you're above the diaphragm, you call it HFpEF. Below the diaphragm, cirrhosis. If you're a diabetologist, you call it type 2 diabetes. Same biology playing out in multiple organs. So this gives us an opportunity to really not think about treating one disease, but treating all of it together by getting upstream and treating the root cause. And this is the future of therapeutics in NASH. So that brings us now to who needs treatment and how to find them. So again, if you go to AASLD and EASL, and this is where I disagree with most of my colleagues, they will say, oh, F2 to F4. F2 to F4 occurred because we need to show to the regulators that active therapy reduces progression to cirrhosis. And because the disease takes 10 to 20 years, nobody has 20 years to sit around and do a study. So we pick F2 and F4 to make the point that our drugs are effective. That does not mean that people less than that do not need therapeutics, because you still have cardiovascular risk, there's HCC risk, and if you think of NASH as a systemic disease that also affects the liver, then you cannot just say, I'm a hepatologist, I don't care about all those other things, I'm only concerned about cirrhosis. You're not a real doctor then. You are just a hepatologist. So you need to be real doctors. You got to think about the whole patient. You got to fix the patient. No point fixing his liver if he's going to die from a heart attack. Your outcome will be the same. So you have to get upstream, and you have to, from a societal level, this is the only relevant and meaningful solution to the NASH epidemic and diabetes epidemic and the cardiovascular disease epidemic and the cancer epidemic worldwide. No question about it, mark my words. Now, focusing it back to the liver, we again target, for the reasons I alluded to, on people who have already started scarring down their liver. And we identify them by using a series of tools. Now, this is an area that needs a lot more work because we have relied on histology, but the death rate from liver biopsy is 1 in 1,000. Even the most recent practice guidelines will tell you that the mortality rate in 1 in 1,000 seems low. But say in the US we have, I did this math, 60 million people who have fatty liver disease. If we were to identify all of them and biopsy and identify if they have NASH, we would kill 60,000 people. Imagine how many jumbo jets of people would die just from our diagnostic procedure. It's completely unacceptable to have a histology base. Histology is great to understand the disease, to study the disease. This is not a public health solution. So we use things basically like FIB-4, NAFLD fibrosis score. Increasingly, I think FIB-4 and APRI are showing to be better than NAFLD fibrosis score because they are sensitive to change as well. They're a lot more robust. And so you can put people into 3 buckets. Young people, low FIB-4, which has a very high negative predictive value for fibrosis, no features of metabolic syndrome other than obesity, their liver-related outcomes in the next 10 years is very, very good. And you can follow them with lifestyle. On the other hand, it's very important, particularly in a primary care setting, to identify those who already have bridging fibrosis or cirrhosis. And some of the clues are increasing age, AST greater than ALT, low platelet count, FIB-4 more than 2.67, APRI more than 1.5, multiple features of metabolic syndrome. If patient has any combination of these, you gotta worry that they have more advanced disease. Elastography, particularly once you have FibroScan liver stiffness over 12 or 13, very high sensitivity, and you can essentially diagnose cirrhosis. And then biopsies are really used in an intermediate category. So what about the therapeutic landscape? I'm not going to talk about diet and lifestyle because that's really still the base on which we build everything. So coming back to clinically meaningful benefit, where we stand, at least in North America, at the level of FDA and in Europe, is we have an accelerated pathway where in the short term, if your drug is acting on disease activity, you got to show improvement in disease activity. If your drug is working on fibrosis, you got to show improvement in fibrosis. And then in the long term, you have to show reduced progression to cirrhosis. If you're already cirrhotic, you either have to show improvement in fibrosis or reduction in MELD progression in the short term, and in the long term, you have to show improved clinical outcomes. Lot of different drugs. You'd get bored if I went through each and every one at a time. So let me summarize the data. These are the data for which we have large clinical trials already published, and they're summarized here. So this is vitamin E, pioglitazone, which are now a little bit old. This is obeticholic acid and elafibranor. And you can see over here that all of these are pretty good for improving hepatic steatosis. And I'll point out to you again that vitamin E still is actually one of the better ones over here. Then in terms of resolution of NASH, again, you can see that, which is an important marker of disease activity. It's still pioglitazone, and there's good data with this. So this is stuff that you can use even today, vitamin E, pioglitazone. Of course, there are side effects with these drugs, and which limit why we keep looking for better drugs. But then you have a smaller effect with obeticholic acid, and in selected patients with the elafibranor over here, we're seeing in a post-hoc analysis improvement. And then there's improvement in fibrosis also. Of these, all of these, the two that were statistically significant were Senecriviroc and OCA. These are very small numbers over here with cilonsertib, which is an ASK1 inhibitor. But over here, these are the two that were statistically significant, but the effect size, as you can see over here, is very similar. And the reason some of these actually hit a p-value and some did not is simply a function of the sample size. If the PIVEN sample size was higher by 30 patients in each arm, vitamin E would have significantly showed fibrosis. If Flint had 30 patients less, it would not have been significant, but the effect size is about the same. So I think we need to be honest about these data. Looking at the newer investigational data, there are a lot of bile acid analogs, and this is FGF. These are data with FGF21, which is a hepato and adipokine showing reduced steatosis. This will come out in Lancet shortly. And then this is the NGM282, which is when bile acid goes to the intestine and binds to its receptor, the intestine releases something called FGF19. This is a recombinant form of FGF19, which does not have the mitogenic properties of FGF19. This shows the best defatting properties to date. These are Madrigal data, which you might have heard about as well. Very, very promising. Modest effect on fibrosis, very similar to vitamin E, not that different. And these are the data with ASK1, small effect over here, at 24 weeks, and then you have obeticholic acid over here. So these are the drugs that are now moving into pivotal trials, and some of these are already in pivotal trials. So in the next 2 years, the final answer will come out for some of these. And when you look at the liver enzyme, which is the other way you assess in these early phase studies whether your drugs are working, you again see that the same compounds actually all have benefit. So when you have an early stage study showing that the fat decreases and the liver enzymes decrease, gives you a lot more confidence that when you go into a biopsy-based study, that you will succeed as well. A compound that may be particularly relevant for Mexico, given the prevalence of diabetes here and NASH, is this molecule called saroglitazar, which is a PPAR alpha gamma. There is an ongoing study, some of you may be participating, there's an ongoing study here in Mexico with this compound, which will read out next year. And these are data in a mouse model of NASH showing very dramatic improvement over here. You essentially wipes out the NASH with saroglitazar compared to pioglitazone over here. It's way, way more effective than pioglitazone. Then there is a direct antifibrotic approach, and these are the Centaur data, and these are the final results. And so what you see over here is the durability of antifibrotic response from 0 to 1 year, 1 year to 2 year. And you can see that those who over here who maintained the fibrosis over here greater than 1 stage, this is placebo active arm. If you got the response, you are much more likely to maintain the response. So it is a durable response, but the total numbers are really small over here, 3% versus 11%, very modest effect size, and so that did not hit a p-value. Another study in the cirrhotic population that has just come out, one was with the lysyl oxidase, which is now 2 years old, and was a completely negative study. And these are the galectin study, and this is galectin is another compound, it's the antifibrotic, and these results were presented at EASL, and essentially show over here, these are the placebo arms, this HVPG was the primary endpoint, and we talked about what that means. No change with low dose, no change in high dose, as you can see. However, in a subset of people with low dose over here, those without varices, they had a significant drop. And I will caution you again, subset analyses, particularly post hoc analyses, very dangerous. You are likely to be confounded and misled by this. So I'm not really that confident how this will actually mature over time. Lastly, can't finish a talk without a word on bariatrics. It works, very good effect size, but bariatrics is not a solution for everybody. It is a hugely resource-intense procedure, and bariatrics has a lot of complications that are associated with it, so we still need pharmacological treatments. So the therapeutic landscape for NASH continues to remain very, very busy. There are over 209 trials, 7 in Mexico that are ongoing. There are 5 pivotal trials. And I think for most of the trials, there are sites in Mexico. I certainly know for Resolve It, there are sites over here. But I think the future, in my view, I think is a FXR pathway. FXRs, we know from Flint, really work. But the problem is it makes your LDL cholesterol go up. So there are a lot of small molecules that do not have this cholesterol and the pruritus problem that are in early phase development. So those are going to be, keep an eye on those. GLP-1 I think is going to be very exciting because GLP-1 agonists have already been shown in diabetic patients to improve all-cause mortality and cardiovascular mortality. Remember, that's the leading cause of mortality. And if you can show improvement in liver disease and decreased progression to cirrhosis, then you got a win, win, and a win. And particularly the oral GLP-1s, which are under development, can cause over 10% weight loss, bariatric level weight loss with a pill that can improve your diabetes, cardiovascular mortality, and liver mortality. So keep an eye on the GLP-1s. The semaglutide trial should read out next year, also towards the end. So that's, I think, I'm very excited about that. ASK1 is already, the stellar trials are underway. They will read out in 2019. Very exciting time in NASH. FGF21, phase 2A completed, phase 2B is starting. And so this is still going to take a little bit of time. But ultimately, we're going to need combinations. If you think about activity versus stage, very low activity, very low fibrosis, lifestyle. High activity, no fibrosis, you need primarily a drug that works on the front end on disease activity. High fibrosis, high inflammation, high cell injury, combination therapy. And then if you have burnt out cirrhosis, then you need primarily antifibrotics. So I will finish over here with a quote from the first medical text, which says, superior doctors prevent disease, mediocre doctors treat the disease before it is evident, inferior doctors treat full-blown disease. And I think these are really words to take home. From a societal level, diabetes, cardiovascular disease, cancer, and NASH are all different manifestations of a common problem. And if we're going to fix this from a societal point of view, we have to get upstream and manage it upstream, reserving drug treatment for those who fail that system. I thank you for your attention.